بسم الله الرحمن الرحيم. أبنائي الأعزاء، أنا دكتور مجدي موسى، أستاذ ورئيس قسم طب وجراحة العين في كلية طب طنطا، والمحاضرة بتاعتنا النهاردة part of the special sense in this semester. وطبعا احنا نظرا للظروف اللي بتمر بيها البلاد والكرايسيس اوف كورونا المحاضرات كلها اونلاين. يشرفني أكون معاكم النهاردة. محاضرتي النهاردة هتكون optic nerve and the retina. So today lecture is going to be about optic nerve and the retina. Central retinal vein occlusion. Other retinopathies, you will have it in the endocrine, like diabetic retinopathy, retinopathy of prematurity in the pediatrics. And we will speak about retina detachment, either primary or secondary retina detachment, where the retina is separated from each other. Let's move to the most common disease we'll speak about today. It's a central retinal artery occlusion, occlusion of the main blood supply of the eye. And occlusion of central retinal artery is cutting off the blood supply of the retina, end up with a sudden painless loss of vision. The patient comes in, he sees no light. He say, something is black in front of my eye, I don't see anything. And because it's an end artery, there is no anastomosis, there is no collaterals like in the well circle in the brain, so it ends up with blindness within 60 minutes if the artery is occluded. Why the artery is occluded? Because different reasons. It's the same reason of occlusion of any artery all over the body. Let's start by thrombosis, thrombus formation inside the artery. And it happens in old age, like in diabetes, hypertension, and arteriosclerosis, where the factors facilitating thrombus formation are there, and we can end up with thrombus inside the central retinal artery. The second common cause is embolism. Embolus means some foreign material is inside the artery. It could be, again, a thrombus coming from the heart, or it could be different material, like vegetations on the heart valve in rheumatic heart disease and endocarditis. And also it can come from the large arteries, like atheromatous lesion in the carotids, as we can see here. We can see atheromatous lesion where cholesterol is deposited, and then showers of this cholesterol will move with the circulation. And these are examples or the sort of embolism. It comes from the carotid, large arteries, and it moves to the central retinal artery. The third least common cause is the spasm, transient, and it causes transit, as in migraine and malignant hypertension, but sometimes the spasm persists, which lead also to complete loss of vision even after the spasm release. This picture showing small cholesterol emboli entangled at the bifurcation of the artery, and we can see the small yellowish particles. These will be called emboli or cholesterol emboli. What are the signs and symptoms? Symptoms, as we said, the patient is presented with sudden painless loss of vision, no light perception or no perception of light. What are the signs? We look at the patient, we examine the pupil. Pupil is dilated, non-reactive to direct light, but if you use the light on the other eye, we call it consensual reaction because of the decussating nerve fibers in the chiasm. But looking at the fundus, we look at the fundus, it's not red anymore. There is a milky white retina, whitish coloration at the central part of the eye, with cherry red spot, with a red spot in the center. This whitish coloration because of the thickening of the retina, or coagulative necrosis, or early edema of the retina, which obscure the color of the choroid. Why this red color in the center, which we call cherry red spot? Because we can still seeing the color of the choroid through the thin fovea, where there is no layers in the fovea, only the retinal pigment epithelium and photoreceptor, and that's why we can see the cherry red spot. What are the other diagnostic signs? When we do fluorescein angiography injecting the dye to see circulation inside the eye, we can see what we call cattle track appearance, black and white, segmentation of the column inside the artery. This is segmentation due to slow circulation inside the artery, and they call it cattle track because the cattle in US are black and white, so when they are following up the cattle in trucks, they see black and white from far away, so this looks like a cattle track, black and white dots due to segmentation of the blood inside the vessels. The next part is the central retinal vein occlusion, and occlusion of the central retinal vein. Also the etiology is almost the same at the artery, except the embolism. We cannot have embolism in the vein, but we can have diseased or sclerotic vessels, as in old age, diabetes, hypertension, and arteriosclerosis. It could be inflammatory occlusion of the vein, and the inflammatory condition affecting the retinal vessels not only in the eye, but it can be also in systemic vessels. And it can happen in young age, like infective periphlebitis and typhoid fever. There's inflammation of the vessels all over the body, and it can affect the central retinal vein. In some autoimmune disease, like Behçet disease, which is an autoimmune affecting the vessels all over the body, especially the veins, with periphlebitis, and they call it occlusive vasculitis, and it can be manifested by other systemic conditions like aphthous ulcer, genital ulcers, multiple nodules all over the body, and it ends up with occlusion of the central retinal vein. Third thing is intravascular abnormality, blood stasis with increased coagulability as seen in severe dehydration and polycythemia. That's why it's very common to find the patient presenting with central retinal vein occlusion while they are doing some exercises, losing some water and dehydration, and they don't drink much. Also, it can happen at night because of the stagnation of blood and thrombus formation ability. The last cause is extravascular cause, pressure on the vein by orbital tumor or inflammatory orbital cellulitis or hemorrhage. Like the picture here in the left side, this patient had a tennis ball trauma with severe hemorrhage under the skin, under the conjunctiva, inside the eye, and in the retrobulbar space behind the globe, where it presses on the optic nerve, and the optic nerve has the vein and artery, and the first one to be occluded is the vein because of the pressure inside the vein is lower than the pressure inside the artery. What are the symptoms? The patients come in with rapid painless diminution of vision. It's not loss of vision, it's diminution of vision, and it's rapid and painless also, and usually discovered in the morning, as I said, because of the venous stasis, the ability to thrombus formation during sleep because of stagnation of blood, and it's very good condition for the thrombus to be formed. Visual acuity varies from mild to severe. It could be 6/9, 6/12, and severe visual loss, counting fingers. Sometimes the patients come in with a very low vision, and we differentiate this from ischemic and non-ischemic type of central retinal vein occlusion. This is an example of the first picture of non-ischemic vein occlusion where the manifestation is there, congestion on the disc, disc edema, congested vessels, tortuous dilated vessels, and macular edema is mild. And the ischemic type sometimes is severely affecting by massive hemorrhage, massive edema, and exudation. Why we classify vein occlusion into non-ischemic and ischemic, depending on a theory that the occlusion happens either anterior to the lamina cribrosa inside the eye before the vein enters the optic nerve, where the thrombus is formed here and there is no collateral vessels to bypass the increased intravascular pressure, while if the thrombus happens behind the lamina cribrosa inside the optic nerve, there are a lot of collaterals between the central retinal vein and the veins surrounding the optic nerve inside the meninges. So these collateral vessels will relieve the pressure, make the manifestation is much less in the non-ischemic type. Let's speak about non-ischemic central retinal vein occlusion. As I said, dilated tortuous vessels. Why? Because we are having thrombus in here, preventing the venous drainage, so the veins are congested and dilated, and there is mild to moderate retinal hemorrhage, few spots. Sometimes you don't find macular edema. There is no much fluid because rupture of these capillaries lead to hemorrhage and fluid, which will accumulate in the most dependent part, which is the fovea. However, the ischemic shows very aggressive picture, massive hemorrhage because of the capillaries are mainly ruptures, many capillaries, a lot of ischemic areas, severe venous congestion, and severe disc edema, and we find diffuse macular edema, which is the cause of marked diminution of vision plus the hemorrhage, which can affect the macula, and also optic disc edema because of the congestion of the vein at the optic disc and impairing venous drainage. Last part of our lecture is retinal detachment. What is retinal detachment? Separation of the retinal layers with accumulation of the fluid under the sensory retina, and separation between the retinal pigment epithelium and the sensory retina by subretinal fluid. What are the types of detachment? As we can see, it's a primary retinal detachment. We call it regmatogenous because it is related to retinal tear or break, or something is torn inside the retina. And secondary retinal detachment where we find no break, but it could be exudative or tractional retinal detachment, as we will speak in a minute. So the main aim is accumulation of fluid under the retina. This is an example of regmatogenous where there is a break in the retina. The vitreous becomes gel and pass through the break and start to detach the retina. So let's start by regmatogenous retinal detachment or primary retinal detachment. It occurs secondary to full thickness defect or break in the retina, and that's the nomenclature coming from. Regma is a break in the sensory retina. As we can see here, this is a rounded break, or we call hole. There is a horseshoe break, and this is we call horseshoe tear. So the tear can be different types and shapes, and it's almost present in the periphery, and fluid start to come in, elevating the retina. What are the predisposing factors? when people get pigmentogenous retinal detachment. If they have myopia, and high myopia, sometimes there's liquefaction of the vitreous, and there's elongation of the globe with a stretching of the retinal periphery, and during stretch, the vitreous is strongly attached to the retina and the periphery, breaking part of the retina, causing the break, and then followed by retinal detachment. Severe blunt trauma with coupe and counter coupe of the vitreous and leading to tear in the periphery of the retina, and then followed by retinal detachment. Peripheral retinal degeneration, weak areas at the periphery, like lattice degeneration, which is also present in high myopia. And there is aphakia, sometimes complicated cases during cataract extraction, will lead to formation of a break due to traction by the vitreous on the periphery of the retina. So this is a picture of large retinal break where the fluid passing through this break coming to the macular area, and this is the cause of diminution of vision. Let's see what are the symptoms. Patients come in with what? Sometimes at the beginning, only masca volitans, vitreous floaters. You see a lot of black objects, which sometimes looks like a, like زي حرف الواو, or there is a comma-like. Sometimes it's rounded, sometimes it's large, sometimes it's web-like. Where this vitreous floater is coming from? Following blunt trauma, sometimes it's hemorrhagic cells. Following blunt trauma, sometimes it's cells coming from the surface of the retina floating in the vitreous. And sometimes it is due to vitreous liquefaction, which happens, as we said, in old age or in high myopia, and start to have some retinal cells inside the vitreous. And the patient comes in with this, especially after severe blunt trauma or inflammation, comes with this masca volitans, and he starts to complain that he's having some black subjects in front of him. Then the second common manifestation, when they are combined together, the photopsia, flashes of light. The patient say that I see flashes of light, especially in the dark. And this is because the vitreous becomes degenerated. Some of the vitreous is still attached to the retina. Pulling on this retina will cause irritation of the photoreceptor, and the patient starts to see flashes. So it means that the vitreous is going to be separated from the retina, and it might tear the retina or making a break inside the retina. So these are very important two symptoms. Floaters and flashes, especially after blunt trauma or in high myopia, it has to be examined thoroughly to find out if there is traction on the retina. Then comes to the retinal break. They said that the flashes are increasing, that the floaters are increasing because of the cells are floating inside the vitreous, and this is the site of the tear where the traction caused break at the periphery of the retina, and then the fluid starts to go through because the vitreous is liquefied, pushing the retina, elevating the retina, and at this stage, the visual field will be affected. The patient will say, if the fluid is in the upper part of the retina, you say, I have lower scotoma. Something is obscuring my lower part of the field. And once the fluid increase and reach the macula, there will be sudden drop of vision. And the most common complaint that the patient say, I have a curtain, black curtain coming from up, and down, and then goes down, and then I lose my vision suddenly because of the macular involved by the detachment, and where the patient comes in and saying, I'm seeing nothing in the central area. What are the signs? We look at the fundus, and we have to examine the retina thoroughly. But sometimes before looking at the fundus, we look at the pupil. Sometimes if the retina is completely detached, we see that the red reflex is grayish because of the retina is elevated and wavy. We don't see the color anymore. And sometimes we see a grayish reflex inside the pupil because of the detached opaque retina. But examining the fundus, we have to find out the tear. This is a horseshoe break, and this is a hole. Sometimes we catch the patient early, a hole without detachment, and we can seal that by laser. But once the detachment happens, it has to be surgery. And the retinal breaks can be multiple like this, and the retinal surface is elevated by the fluid, and it will be convex in nature. And this is the retinal detachment, convex anterior displacement of the retina with convexity, and we can see that the macula is detached, and this patient comes with sudden drop of vision after flashes, floaters, and scotoma. How about the secondary retinal attachment? Secondary retinal attachment, we said we have two types: exudative retinal attachment, which is caused by something under the retina, pushing the retina from below, like in the choroid, and making fluid accumulation under the surface of the retina, like choroidal tumors. Malignant melanoma of the choroid can cause exudative retinal attachment. Choroidal inflammation, like Harada disease, which is an autoimmune disease with a multifocal inflammation in the choroid, pushing the retina like this, multifocal inflammation, and then fluid will be accumulated in the central area. Or degenerative disease like age-related macular degeneration. We have something called choroidal neovascular membrane happens in the choroid, which will lead to hemorrhage and exudation and elevation of the central retina, and these are all causes of secondary or exudative retinal detachment, which means a lesion under the retina, accumulating fluid and pushing the retinal layers to be separated, causing exudative retinal detachment. The last type of detachment is, or the secondary type also, tractional retinal detachment. Tractional retinal detachment means something is pulling on the retina from the surface. So the retina is pulled away from the RPE by contracting vitreous membranes like this. This is a proliferative diabetic retinopathy, advanced stage of diabetic retinopathy, where a lot of membranes, a lot of fibrous tissue happens because of the bleeding and long-standing diabetes, which can cause traction on the surface of the retina, leading to what we call tractional retinal detachment. And the most common cause, as we said, proliferative diabetic retinopathy, other retinopathies like sickle cell retinopathy. RVO can cause hemorrhage and fibrosis in the vitreous and can cause traction retinal detachment in advanced stage, and sometimes penetrating posterior segment trauma when patient had a foreign body inside the eye, initiate fibrosis and reaction, which cause tractional retinal detachment. This is an example of old branch vein occlusion where the fibrous tissue happens due to the hemorrhage, long-standing hemorrhage, and there is a traction on the retina, and we can see pulling on the retina and distorting the retinal vessels and fluid accumulation under the retina. This is the end of my lecture, but let's have a couple of questions like testing your knowledge. The first MCQ question I will give you, depending on the lecture, what the passive non-inflammatory swelling of the optic nerve head is termed or is called papillitis, papilledema, or retrobulbar neuritis. So it's obvious it's papilledema because it's passive, it's non-inflammatory swelling of the optic nerve head, and the right answer is papilledema. Second question in the form of like a small problem we need to resolve it, like 60-year-old male known to be hypertensive for 5 years. He developed marked diminution of vision in his right eye, started 5 hours ago. The patient described the diminution of vision to occur suddenly. It means he opened his eye, the second he doesn't see anything, and on examination the visual acuity was no light perception, he's not seeing anything, pupil dilated, non-reactive, and the fundus is milky white with a cherry red spot. So which one of the following pathologies can be the diagnosis of such presentation based on the lecture we had? Is it acute angle closure glaucoma? Is it central retinal artery occlusion, central retinal vein occlusion, or papilledema? And it's obvious that sudden, painless loss of vision is the central retinal artery occlusion. Last thing, short AC questions when it comes in the exam. We ask you to enumerate 4 signs of optic neuritis. We have many signs in optic neuritis as we spoke in the lecture. Could be decreased visual acuity, blurred edges of the optic disc, filling of the optic cup, elevation of the optic disc over the retina, not much elevation, but there is elevation, turbid vitreous and tender globe while we move the eye, or pain on eye movement. So it means we have many signs, only 4 of them, you will get the mark. Thank you so much for your listening, and I hope the crisis will pass and everybody stay safe. And this is my email for further communication if you need to communicate with me. Thank you so much for your listening, and this is the end of the lecture. I'm Dr. Magdi Musa again, Chairman and Professor of Ophthalmology, Faculty of Medicine, Tanta University. Thank you so much.